Welcome to the Catalyst Podcast, brought to you by Chestnut Health Systems. I'm your host, Charles Epstein. Joining me today are Charisse Montgomery, Family Services Coordinator with Chestnut Health Systems, and Lindsey VonDras, Perinatal Care Coordination Manager for the Missouri Hospital Association. Charisse and Lindsey are joining me today to discuss the maternal health challenges in Missouri related to mental health and substance use during pregnancy and postpartum. Ladies, thanks for joining me. Much appreciated.
Thank you. Happy to be here.
Thanks for having us on.
Yes, thanks so much for taking the time. So before we really get into the particulars, I'd like to take a step back and, if you would, set the stage for our listeners for maternal health in the U.S. and the role played by peers and doulas. Charisse?
As far as the mental and maternal health is concerning in the United States, maternal health of birthing people from perception to pregnancy to childbirth over the last immediate years has been very extreme. The United States currently has the highest maternal mortality rate of any high-income country, with maternal health deserts and deaths estimated at 1,000 births per year. So out of all of the women in the United States, or all of the birthing people in the United States, there are over 1,000 a year. That's sometimes even higher than quote unquote third world countries. So it's very alarming that with the United States, from postpartum, even from 6 weeks up to 12 months, poor maternal health, has issues all over the United States.
Is there any one or two reasons for that actually is kind of shocking?
It is shocking, and it's mostly not being able to be directed to the care that you need. It's a lot of things that go into about, we have maternal health deserts. We have lack of healthcare in general. Some people cannot afford, they're maybe $2 or $3 over the poverty line, so they don't qualify for some Medicaid programs. Some people, it's provider bias. They go in, they have a bad experience at one time in their life, they don't go back. And so there's so many lacks in services and care just because people don't feel comfortable to go. And then when they do feel comfortable to go, they're not able to get there. There are transportation issues. There are money issues. There are other family issues. So it's a lot of things wrapped up in maternal health here in the United States.
Thank you for that, Charisse. So let's get right to it. What does the data tell us about how mental health challenges and substance use disorders affect pregnancy and postpartum outcomes generally, and for Missouri families specifically? Lindsey?
So I think one of the clearest messages from both national and Missouri data is that mental health challenges and substance use disorders are major contributors to poor pregnancy and postpartum outcomes. When we look at our Missouri's most recent pregnancy-associated mortality review, which looks at all maternal deaths in the state, mental health conditions, including substance use disorders, continue to be at the top of the list for maternal mortality and severe maternal morbidity. The last year's report showed that 30% of deaths were contributed to mental health and substance use. And just recently, another report was released a few weeks ago that showed 22% of pregnancy-related deaths were due to mental health and substance use as well. And that data was from between 2019 and 2023. And I think the most important takeaway from that data was that of all these pregnancy-related deaths related to mental health and substance use, 100% of them were determined to be preventable. So that's really what drives the work that we do through the MOPQC. It also showed that nearly 40% of pregnancy-related deaths occurred during the postpartum period. So that was between 43 days and up to 1 year postpartum, often a time where traditional care tapers off. And so moms might not have the support, might not have as much support during that time. It also extends beyond just maternal health and maternal morbidity. We see these effects across system level and across family systems. Nationally, more than 72,000 children entered foster care due to a parental drug or alcohol use in 2022. That's the latest data that I could find. And more than half of those were infant removals. And then in Missouri specifically, our rates are even higher. About 46% of foster care placements were linked to parental substance use, and fewer than half of those families ever achieved reunification. So it just shows that that substance use and mental health challenges can have lasting effects, not just to moms, but to entire families and systems.
Yeah, this is really alarming, eye-opening stuff. And, maybe it's my own myopia, but I wonder if these are issues that, many people are unaware of.
I
I
think
would
many
like
people are unaware of that. I've quoted that statistic many times and find that most people find that very shocking. They think of the families that have open cases with children's or child welfare, that the families eventually achieve reunification, and sometimes that is the case, but oftentimes it's not. Oftentimes that has lifelong impacts.
Yeah, Charisse, you were about to say something to that?
Oh, I just wanted to add, under the umbrella of mental health, on the national average as well, as far as racial inequities are concerned, that is a higher rate when it comes to African American women. We are 2.5 times more likely than white women to be dealing with issues of maternal mortality. And it's because of, systems issues, later trimester care and missed appointments, just because not feeling safe in spaces. And that's one of the bigger drivers as well, not in front of, but alongside of maternal mental health. That is something that we need to deal with system wide, to make sure moms feel safe and they'll go in and they'll get the care that they need. So I just wanted to mention that as an added driver that's really serious and it's really dangerous. And a lot of work needs to be done in that area as well.
Indeed, I'm glad we're talking about this.
Can I
So,
add one more thing to this as well?
sure, go ahead.
Just in terms of the data, one thing that I did want to mention, I know a lot of the statistics that I provided were more negative, but I do want to mention that this is also a very powerful time to intervene. I think this is it's important to recognize that pregnancy and postpartum are also powerful opportunities for engagement. I think a lot of individuals are highly motivated during this time to improve their health and well-being, not only for themselves, but for their baby. And this is also a time where individuals are interacting already with the healthcare system. I think there's a misconception that moms that are struggling with substance use aren't always seeing their providers, which is true at times, but we do know that looking at Missouri hospital data, that moms with substance use disorders are going in for these appointments. We see that looking at first trimester encounters at Missouri hospitals, almost 9% of encounters during that first trimester had an SUD diagnosis attached to it. And so that's also, it comes down to over 19,000 healthcare encounters that could be a time of intervention.
So, which actually begs the question, what are the biggest barriers that make it so difficult for birthing people in Missouri to get the support they need? You touched a little bit on this. Charisse?
A lot of the barriers are, Missouri is vast and wide and it covers a lot of rural territory. And so in a lot of the rural territory, there are no healthcare providers or very, very few healthcare providers. And so that's the access to care. Also in those areas, there's like a transportation. People are struggling. Money is tight. Groceries are high. Just to maintain yourself and your family is growing cost. So that's causing a lot of issues. Behavioral health, as Lindsey has spoke about, is a lot of the issues. Just being able to get to a facility to birth. Sometimes you have to go miles and miles, sometimes over 20 miles just to get to a prenatal appointment, or 20 miles just to get to a hospital when you are in labor. Governmental services, we talked a little bit about Medicaid, being able to qualify for those services. It's a plethora of things that keep, Missouri families and, maternal health families overall, or keep them bound and keep them feeling like they don't have the needed resources at hand to be able to, move through and have healthy pregnancies and be able to get the care that they need.
Anything to add to that, Lindsey?
Well, I think Charisse brings up a good point about the access. I think access is huge. Missouri also is higher than the national average for maternity care deserts. I believe almost 52% of Missouri counties are considered to be maternity care deserts, meaning families have limited or no access to OB care. I think another one is stigma. I think that is so huge when it comes to barriers, because it impacts a person's motivation to even want to seek help in the first place. I think a lot of moms are worried about being judged, being labeled as a bad parent, being treated differently by providers. And as I mentioned earlier, child welfare involvement is a huge concern. It's not, and that's for a reason that a lot of families
Sure.
are being impacted. And so I think that fear really impacts patients even wanting to have those conversations with their providers. And if they can't have those conversations, they can't get the help that they need. So I think that is a big barrier. And not just on the patient side, I think on the provider side too, there's still a lot of stigma. There's still a lot of hesitancy for providers to even feel comfortable to bring up substance use. It's not normalized. It's not looked at as a medical condition. A lot of times it's looked at as a moral failing. And so I think that prevents people from just talking about it like any other medical condition. And so I think that that's one of the biggest barriers.
You already mentioned how families are affected by this. So if you could, for our listeners, paint that picture. How are families brought into this process where the impacts on them are perhaps mitigated?
We all know that whether families are living in the same houses or families are sharing the responsibility in different households, the whole family has to be coordinated in to make sure that the mother and the child and the other people that are, a part of the family feel seen and feel heard, and just have some coordinated family-centered care. And so, things like shared goal setting, where the family and the providers map out a plan together. People are the experts of their own lives. And sometimes in clinical settings, sometimes, as Lindsey talked about, biases, we feel sometimes that we may know best for families, but families are the experts of their own family. So making sure that we bring the entire family in if they want to participate and talk about healthcare needs as well as other needs in the family is great. Centralized navigation. Have one coordinator, maybe a community health worker, maybe a doula, maybe a case manager that could come in and pick up different aspects of healthcare. Some about the maternal health, some about the social determinants of health. Being able to find community resources and bring together team communication. Everybody in the team, from the healthcare provider or the mental health provider or the substance use provider, the navigator of services outside of things that are medical, everybody needs to come together to ensure that the family has everything their needs. And also somebody to connect the resources. There are community resources as well as clinical resources. Having that one person, maybe a home visitor, to come in and to be able to sit down with the family and talk about their needs and what the family needs and not what we think they should need. Everybody just coming together to make sure they support the family as a whole is really an important driver of ensuring that the coordinated family and the care is family centered and the family feels safe.
Yeah, yeah, I like that. What do you say? Everyone is an expert on their own life?
Everybody is an expert on their own life.
I
Absolutely.
I like that. Any thoughts on that, Lindsey, about how it's important to offer different recovery pathways and meet families where they are?
I think we need to look at recovery as unique to each individual person. Every person is unique. Their circumstances are unique. They have different strengths. Their recovery goals are unique. So it's difficult to look at recovery as a one size fits all approach. Because when we think about substance use and substance use disorder, this could be a very broad range of experiences. It could range from, someone who smokes marijuana during pregnancy or another person may have a severe opioid use disorder. I think when we think of substance use, we think of one blanket term, but really it could be a broad range of different experiences. So I think every person is going to need something else. What works for one person is maybe not going to work for the next person. And so I think, like Charisse was saying, it needs to be very patient. Care needs to be very patient centered and needs to be very individualized to, what social determinants of health does this person have? What are their strengths? Uh, what are their challenges? What substance are they, struggling with? And um, finding out what their recovery goals are and not just referring every patient that screens positive for substance use to the same provider or the same kind of program.
Right.
I think for some people, medications for opioid use disorder might be life-changing. For other people, they might find a recovery group and peer support and go the more faith-based abstinence route, and that works well for them. So I think we just need to center the patient, center the client, the individual, and figure out what's going to work best for them. And maybe they've tried a treatment program in the past and that didn't work for them. And I think the message is letting them know just because you tried one thing doesn't mean there aren't other options for you, because there are a whole
Mhm.
menu of options and a whole, plethora of services available and different roles like doulas and peer support workers that can help along the way as well.
I wanted to get in there and just add a little bit. I'm sorry, Charles, because and the different pathways is absolutely what we need. Because when people hear substance use and use disorder are two different facets. Substance use is just a general act of consuming a substance without necessarily causing any harm or dependence. So, drinking a glass of wine at dinner with your family or a family celebration, that's substance use. Substance use disorder is a diagnosed medical condition where a person keeps using a substance even though it causes major harm, health issues, or trouble at work, home, or school. And so that is the difference. And that's where the stigma comes in that Lindsey was talking about, because having a drink at home with your family or a celebration, that's not frowned upon. But a substance use disorder means your mind and your body. Your mind takes on a different level of substance use when you have substance use disorder. It's affecting other things in your life that normally would not be affected. And in order to get to that, as Lindsey talked about, proper screening is necessary, because everybody that use substances don't necessarily need CPS called in to have their children removed. So it has to be something where we sit down and do proper screening and have the individual conversations and try to understand overall what is going on with this family, because reporting that you use substances and saying that someone has a substance use disorder is two totally different things. And we have to make sure that we are doing our due diligence to make sure that people are not, for lack of a better word, people are not, being labeled, quote unquote, for something that's not necessarily they're struggling with.
And I completely agree with that, Charisse. And I think that is why it's sometimes it's sometimes misleading to just go off of a substance use, like a urine drug screen. It might tell you point in time what that person has in their system, but it doesn't tell you anything about their lifestyle, about their habits, about if they actually have a substance use disorder. And so I think that's a really good point.
Yeah, and the other issue, of course, is when you introduce the family dynamic, whole set of other complications. You may not have a fully supportive family. You may have family members who themselves are grappling with certain issues.
And I will say, too, I don't think there are enough family-centered services in Missouri or just in general. I think substance use care has been so individualized and not recognizing that, yes, it does affect the entire family unit. And I just think of new moms who just had a baby and maybe they screen positive for substance use or were identified to have a substance use disorder. There aren't many programs that keep mom and baby together. There are a handful, but there aren't enough. And there needs to be more, I think, more focus on how do we bring in the family? How do we keep families together and provide the care while doing that?
So tell our listeners about Project Stork. Why was it developed? And how does its model of peer support combine with care coordination help bridge the gaps we've been discussing?
Before we get to that, Charles, I want to make sure that I get back to, because we did talk about peers and doulas as helpers to help families thrive. We kind of got off of that, but I do want to go back to, because I am a doula and I am a certified peer specialist, I do want to talk about some of that family-centered care and how doulas can help support that and also get them over to resources that they may need for mental health and substance use health as well, because we do have a program in Chestnut in Illinois. I know we're talking a little bit more about Missouri, but I do want to highlight that we do have a program in Illinois that connects doulas that who are peer recovery specialists to the programming that Lindsey was talking about.
Okay, well, now's the opportunity to expand on that if you'd like.
So as a family service coordinator here in our pregnancy and postpartum program in Illinois under the Chestnut Health Systems umbrella, we do have a program that connects doulas with levels of care to address mental health and substance use disorder. And so, with our doula support, we do a little bit of home visiting. We do mental health screenings. We talk about gestational risk as well as general wellness. We have lactation guidance, nutrition, infant sleep safety. We connect to community resources and connect to government resources like WIC and SNAP and medical benefits. Also with our program, we connect directly to medical assisted treatment recovery within our wraparound services at Chestnut. And we also have that doula support, which means it's educational, it's informational, and it's also physical support, not only for the birthing person or mom, but also for their families. Some of our families, we've connected partners as well to treatment. As Lindsey had talked about a bit before, it should be family centered. Some of those families, are well into generations where substance use disorder or mental health has been generational. And with our program here in Illinois, we are connecting families. So if a father wants to have doula support as well, if the father wants to go in for treatment, if the father wants to go in for mental health services, we can provide that wraparound care not only to mom and baby, but also father and partner.
Very good. So tell our listeners about Project Stork. Lindsey?
Yeah, so Project Stork is a new initiative of the MOPQC that we've been developing for this past year, and we're preparing to pilot across Missouri coming up in 2027. STORK is actually an acronym. It stands for Strengthening Treatment Access and Ongoing Recovery for Key Maternal Populations. And essentially, it has evolved to be less of a program and more of a team-based point of care framework designed to improve care for pregnant and postpartum individuals affected by substance use disorder through identification, trauma-informed response, and connection to maternal peer support, treatment, and other community-based services. The project initially grew out of the idea of wanting to expand access to maternal peer support for this population and better integrate peers into maternal health care. We looked at models like the EPIC program, which is Engaging Patients in Care Coordination program, that has seen a lot of success using peers or recovery coaches for individuals with substance use that may have had an overdose incident or appeared in the emergency room. And working with those peers, those patients were able to connect with needed services, connect with a peer. And so I don't think we've got the opportunity to talk much about peer support, but peers are really individuals with lived experience of a substance use disorder, mental health challenge, who have navigated recovery and who can then be a supportive person for somebody who's struggling with similar circumstances. And so they really bring hope to individuals that recovery is possible. They build relationships, provide a lot of encouragement. And so we really wanted to incorporate peers in working specifically with this population, pregnant and postpartum moms. And so it kind of evolved to be more of this framework. In, talking with Missouri providers, one of the things that we heard a lot from providers was many of them were already implementing the evidence-based practices of SBIRT, which is screening, brief intervention, and referral to treatment. They were screening and identifying individuals with substance use, but what they were having more difficulty with is that referral to treatment piece. Like I said, they were screening, but actually getting people connected to treatment and recovery support, that was the more challenging piece of it. And so we developed Project Stork to build off of that framework of SBIRT and to help strengthen the referral to treatment process. And so the framework really defines how clinical providers and maternal peer specialists and community organizations can work together, and turn just identification into meaningful connection and ongoing support. And so the clinical care team would be first identifying the needs and initiating the connection. The maternal peer specialist would be, providing that lived experience support, the trust, the encouragement, the trauma-informed response. And then the community providers are really there to offer the treatment and recovery support, the housing resources, and all the other needs that are identified. And so it's more of it's less of a referral alone, but more of creating a system of care around the person and better coordinating care so that individuals can get connected to the supports that they need. We are currently working with and have been working with 6 pilot sites in Missouri, 4 clinical sites and 2 community sites. We are planning to potentially recruit a couple more sites and are working towards implementation later this year.
I probably should have asked earlier in this conversation to make distinctions between and among peers, doulas, and others who were part of this whole support network. And Lindsey, you started actually to do that. Charisse, any thoughts there so people understand the differences among those different roles in providing this kind of support?
Well, as far as doulas and peer recovery is concerned, this is non-medical and non-clinical. So those two particular services are much needed services, but more outside of the clinical realm. So doulas, I had already spoke to that early. And peer support, so in our program, we have both. They are dual role positions. And so with the great definition of peers and what peer support looks like that Lindsey had already given, is really nothing to add to that. They are just 2 components that are actually put together, especially in the maternal health population, because the doulas do more of the physical work, when it comes to birth and labor and how to take care of baby, that type of work. And the peers do most of the navigating and the support around the substance use or mental health portion. And so there are two distinct roles, but they work together to make sure to support the entire maternal health of clients that we see within the START program.
Okay, good. Thanks for that clarification. Final question. Lindsey, what made Chestnut a strong early adopter site for Project Stork?
Well, I think the reason we decided to bring on Chestnut as one of our early adopter sites is because they were already working extensively with this population. They were already working with pregnant and postpartum moms with substance use. They are, well integrated in their community and had already been integrating peers into their programming before Project Stork. And so one of the goals of Project Stork is we wanted to build a bridge between these clinical care and longer-term community supports. And so we decided, instead of just bringing on all clinical sites, we wanted to bring on a couple of community sites as well. And Chestnut was a good candidate. Like I said, they already had peer support. They already had all of the services in place. They were already doing the work that we needed them to do. And it was more so finding how do we now bridge the clinical care to community sites, and how do we get clinical providers to utilize the services like Chestnut so those moms can get connected to longer term supports outside of the clinical encounter.
Your thoughts on this partnership, Charisse?
I think it's a wonderful partnership. Lindsey has welcomed Chestnut in with open arms. And, as she did say, we have, Chestnut was built on peer support from their inception, a little over 50 years ago. Peer support has always been a part of Chestnut. Chestnut has within the last 6 years adopted the pregnancy and postpartum model. And so it was, we worked that out. We had got an initial grant for that under our umbrella, and we did that, throughout the grant period, and it worked so well, and it did so well within the community, being able to support the maternal health population, that when that initial grant period ended, Chestnut picked up the program and we kept it and we solidified it. And so they found out that it is a great need. They found out that it is a great benefit to families. And that's something that, we're still in the process of expanding. And like I said, we've been out there for 50 years, and the maternal health portion of this was just so important and just so needed. And our numbers were really great for engagement, not only engagement with, the women, but also engagement with their families. And also some of the women that was a part of our maternal health and peer support program actually became staff of peer support within Chestnut. So, that's just a testament of, the maternal health work that, we have been doing and how it has been received by our communities.
Great. I'm really glad we had a chance to discuss this. As I said at the outset of this conversation, some of this stuff is really, really alarming and eye-opening. So I'm glad we were able to shed some light on this. Charisse, Lindsey, thanks so much for taking your time. I really do appreciate it.
Thank you
for having us on.
Today, I spoke with Charisse Montgomery, Family Services Coordinator for Chestnut Health Systems, and Lindsey VonDras, Perinatal Care Coordination Manager for the Missouri Hospital Association. This is the Catalyst Podcast, brought to you by Chestnut Health Systems. For more, visit www.chestnut.org. This is your host, Charles Epstein. Thanks for listening.